No relevant disclosures to this talk. Our learning objectives today, I wanted to give you guys a broad sense of how best to approach a patient. There are so many nuances to trauma surgery in general, whether non-operative or operative, but I feel like this talk is going to be general in terms of how to approach a patient and how do you utilize trauma classifications and identifying their injuries, making that a basis for your goals of your surgery, when it's appropriate to use mentors, and how to handle difficult situations and how best to optimize your team. We'll start with a case. So this is a lady I took care of last year. She's a 35-year-old female who fell from a two-story roof. She's a Spanish-speaking construction worker, and she's about 120 pounds. She comes in with this pathognomonic pure bilateral facet dislocation at C7T1 with a anterior end plate fracture at T1. And we are going to discuss through our learning objectives how this patient would benefit from a utilization of a standard algorithm. This is her other sagittal where you can see it's a pure facet dislocation. So when you're approaching a trauma patient, it is important to remember that you're probably not the first person they see. And because we're spine surgeons, I want to kind of hone down on more of the surgical side of things, but you need to be able to discuss with whomever the first person is who's going to take care of your prospective patient what their protocols are. At every pretty much level one trauma center, ATLS protocol is standard with a primary and secondary survey. But then it gets muddled. Does this patient have a single injury? Are they a multi-polytrauma and the trauma team is responsible for them? And really educating your staff on how to recognize that a patient is in neurogenic shock. Or if they have a spine injury, what other injuries should you be aware of? And having this heightened clinical awareness if a patient has this massive facial trauma, you need to make sure that they don't have any other cervical spine injuries. Issues notwithstanding, at the University of Iowa, we take care of a lot of geriatric patients, but you have issues with comorbidities that also become part of this picture. Does the patient have diabetes? Are they osteopenic? Are they osteoporotic? Do they have DISH or ankylosing spondylitis? Understanding how to approach each one of those situations while also educating not only your residents if you're in a teaching facility or your APPs, but how to show the ER that you care that this patient's blood pressure doesn't dip below a MAP of 80 if they're in neurogenic shock because you understand the algorithm of their spinal cord injury. This is an example of an algorithm chart. This is actually from Harborview, but what it's mostly indicative of is by the time that patient gets to us, they're down here. So they're not necessarily, we're not the ones controlling whether or not they got a CT, whether or not they, get x-rays. But I do think wherever you are practicing, understanding the trauma algorithm that you are being a part of the system is really important, because maybe if they got to me and they really didn't have the full, CT C-spine or full CT of their entire spine, where in the algorithm were they lost, and identifying those issues and discussing them with your staff at your trauma facility is really important. On the evaluation here at the University of Iowa, the first person from the spine team who sees the patient is my resident, and educating your residents on what a full neurologic exam means. So I've been in 3 different institutions in the past 6 years, and that is different. And I didn't realize that a full neurologic exam, although it has the key points, may be missing some nuances. And if you're not educating your residents on what to look for and how to educate them what a neurologic change looks like, a neurogenic shock, you might be missing the grand scheme of things. This patient might be having an incomplete neurologic exam or workup. At our institution, every trauma patient gets a full CT spine as we do it, identifying whether they're a high energy mechanism or a low energy mechanism, but requires full spine imaging. There are non-contiguous injuries in these trauma patients, especially high energy. It can be anywhere from 10 to 19%. If you are a tertiary referral center, such like we are here at the University of Iowa and at Harborview, you might get a patient that has not complete imaging, and you need to be able to recognize that. Does the full CT spine show the craniocervical junction. A lot of people kind of just blase over that in a CT scan from an outside institution, and you can miss a occipital cervical dissociation or a higher up injury if the CT spine is below the level of the craniocervical junction, and then the CT head doesn't show you an adequate representation of that junction. Resuscitation, again, who is responsible? Are you responsible as the spine surgeon to make sure that there are MAP goals, to make sure that the patient is, in the ICU? I know that steroids and part of a resuscitation program are very controversial, and we're not going to talk about that, but there have been instances in places that I've worked where steroids were given to younger patients, and understanding the complication profile and the dosing and timing of that dosing is really important. If your trauma team is really involved with this, the general surgery team, the orthopedic trauma team, it is more helpful, but you can't just walk into a situation as a new surgeon and be like, oh, my patient's going to be fine, and realize that they're not. There are a few parameters that I think is really important in the evaluation of a patient. If you're working at an institution where your MRI is not available for you overnight, that might be an issue you might come up with, and that's really important to address with your radiology staff on how best to get an MRI when it's appropriate. There are two reasons that I think in my approach to a traumatic patient that I would get an MRI. One, obviously, if I'm going to reduce the patient and they're not able to contribute in an exam. And another is when a patient presents with a neurologic deficit that does not support the fracture that I see. I think that those are my two main reasons, mainly because where I've trained before, MRIs do slow down the process. I've been told that's not the case here. Recognizing that you have to treat people based off their mechanism of injury. This gentleman up here in the left-hand corner is a same level fall. Yes, he has ankylosing spondylitis. Yes, he needs a full CT workup with an entire spine view to make sure he doesn't have any skip injuries, but that is a different animal than this gentleman who is splunking, or this lady who fell off 2 stories, and how you treat them can be different. You also need to recognize that these patients, especially ankylosing spondylitis patients, are more likely to have spinal cord injuries or hematomas. Trauma classifications. Trauma classifications happen when most oftenly in an academic setting. And I think that they're directed mostly to people who work towards or alongside in teaching institutions. But if you're in an outside institution and you're still taking trauma call, it is a good way to describe an injury. And as any classification, whether it's for spine, trauma, or orthopedics, it should be comprehensive, reproducible, usable, and accurate. This is the trauma thoracolumbar classification from the AO spine. And the good thing about this is this, it has been reproduced, and about 90 different trauma surgeons came up and said, yes, an A4 injury, a complete burst injury, is something that is readily identifiable, reproducible, usable, and accurate. Unfortunately, there's no one classification, whether it's the morphologic classification, the AO classification, whatever you choose to use, that has been shown to facilitate a full outcome. But I think if you're at a teaching institution, you're working with residents, it's a lot easier if they call you in the middle of the night and they're saying, hey, I've got this lady who maybe has a burst fracture, there's some degree of retropulsion, maybe has a posterior ligamentous complex injury, not sure, versus, hey doc, I've got a L1A4 complete, incomplete, gives you the neurologic exam. It gives you a little bit more of a communication, and it's reproducible. Goals of surgery. So there are non-operative treatment of many traumatic spine injuries, but since we're surgeons and since I only have 20 minutes, we're going to focus mostly on the goals of surgical treatment. The spine function is ubiquitous and most people have their own definition, but it provides stability, range of motion, and the protection of neural elements. If you have a patient that has a fracture that can be treated closed in a collar or in a brace or without any, and they still are able to have stability, range of motion, and protection of the neural elements, then you can treat them non-operatively. For the purpose of this talk, the treatment, we're going to guide it more to providing biomechanical support, saving as many motion segments as you possibly can in young, healthy kids. That's really important. And whether or not there is a need for decompression. There is no quick formula. Try not to make this harder than it has to be. But I think when people say they always or they never do something, it leads down a rabbit hole that will be very difficult in treating trauma patients in general. Your goals of your surgery depend on various parameters. Whether you go anterior or posterior also depends on the parameters of the injury itself. So whether it's a high energy mechanism, maybe they require a 360 fusion where they have an anterior and a posterior construct, providing that biomechanical stability to restore the integrity of the spine. Maybe a low injury, they don't. You just need to restore the tension. If they're a flexion distraction injury and an old lady, same level fall, still kind of a decent injury, but maybe only going from the posterior side and restoring the tension band is adequate in that sense. The extent of the injury, understanding if a patient has a single segment injury or multiple segments. I treated a patient who had a floating lateral mass that got a 2-level ACDF, and they happened to have a non-displaced atypical hangman's fracture that we treated closed. That doesn't mean that you had to fuse them all the way, from C1 to C7, but if they did have those injuries, understanding when it's enough. Degree of deformity, again, this is ankylosing spondylitis, so it's a little bit different, but minimally displaced injuries versus a full spondyloptosis or dislocation is a different animal. Bone quality. Here at the University of Iowa, we have some difficulty with bone quality in other places. Understanding when to use cement, the extent of your construct. It's pretty hard to ask an osteopenic patient to heal a thoracolumbar burst fracture that you're treating with a short segment fusion. You need to go probably longer in order to provide adequate stability. Location of dural compression can be really important when you're going to approach how you're going to treat this patient. If the patient has more than 67% canal compromise, there are biomechanical studies that show that the degree of ligament ataxis and attaining an indirect decompression with a posterior fusion alone is likely inadequate. However, if the patient is intact, if you do a posterior fusion with a laminectomy, and you get a post-op CT scan and you see how well you were able to indirectly decompress them. I have seen patients who remained intact neurologically after that treatment, who did not require further surgical intervention. And after a year, they maybe got an incidental CT abdomen pelvis for another reason. And what actually happens is that the pulsations from the dura make the cancellous bone that's retropulsed into the canal resorb. It's actually really impressive, and I never knew that happened. A lot of times though, if they have this amount of dural compression and they're a high energy mechanism, it's probably benefits you to provide anterior column support and do a corpectomy a few days later. Coordination with your subspecialties is very important. Here at the U, we have trauma surgeons who we work with lumbopelvic fixation, and or if a patient has other injuries that require further operative intervention, you need to talk to them. You need to understand, hey, this patient isn't resuscitated well enough. I can't do a big lick on them, so I'm just going to stabilize them, versus this patient needs their femur fixed while they need their spine fixed. And working well with your orthopedic trauma colleagues and your neurosurgical colleagues is paramount. The most important part of your goals of surgery is understanding what you are capable of. If you have never done something, it does not mean you cannot do it. However, you need to understand which surgical procedures are in your comfort zone. Most of us who've trained have done some version of a posterior fusion. But if you're having to deal with a great deal amount of indirect decompression and reduction maneuvers and techniques that you've never done, maybe this patient should be transferred to a higher level of care if you're not the end stop. And if you are the end stop, then knowing when to call in help. Knowing when enough is enough. Again, we talked about high energy patterns versus low energy patterns. This lady is a type 2 dens from the same level fall. You fix her with a C1-2 posterior fusion. She's out of her collar. She's doing great. Versus a lady who had a 2-story fall and she needs a 360 fusion. Using your mentors and your partners is very, very important, but you need to have an understanding of when to call and when to get over this learned helplessness that I feel that young surgeons potentially can fall into. We don't have our our badge of courage and our attending behind us. And so a lot of it becomes very scary, and you need to know when to use your phone a friend. I also think that understanding your own support system and creating an environment where you have support gives you more confidence in order to do these things eventually, and be the person that you need to be for your patient. There's sometimes where, maybe I just talk to my co-fellows, shoot them a text or say, hey, I've got this. What do you think? Versus, maybe calling in my partners for a bad case, or, showing them some x-rays and making sure maybe they're around for my first few cases, and then knowing when to call in the big guns, knowing your fellowship attendings, knowing what they would probably say. If you're answering your own question, it's probably, maybe not the best time to call them. Or if you call them, make sure it's worth it. I had an attending in residency who told me, anytime that you're brand new, always load the ship. It's never wrong to call somebody, but knowing when not to call is almost just as important. Handling difficult situations when we're young becomes even worse when you're brand new. I think as a fellow, this is one of the last cases I did. This gentleman came in with a catastrophic ankylosing spondylitis injury from an outside institution, and we literally reduced him, almost just like a femur in the operating room, and everyone was really calm, and we identified the issues that we knew this patient was going to have prior to starting. Also, if you're at a new institution, knowing your resources. Does your MRI scanner work overnight? We talked about that. Does your institution provide stainless steel tongs in order to adequately reduce jump facets? Do you have titanium tongs to know when you can put somebody in an MRI scan and traction? If you do have intraoperative complications, because we all do, and they're all going to come, take control of the situation, turn off the music, be the captain of the ship, but stay calm. I think QI meetings are an underrepresented part of the hospital administration. I think there's a difference between hospital administration and surgeons, and I don't think we get along very well, at least from my experience. But I do think you should utilize QI meetings as a way to learn, and as a way to change a issue or resource that you would have been more successful with if it was identified prior to the complication. How to best optimize your team. So every patient I've ever seen, the fastest they would get into the operating room, even if I was meeting them at the OR or the ER door and bringing them into the OR myself, is likely about 2 to 3 hours. You're going to have time. And every single patient that I had this happen to, I would make a list, starting at the very beginning of what I was going to do for surgery until the very end. Then I would hand that list to the circulator and be present for the huddle and say, hey, we need this, 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 and this. Getting everyone involved and knowing how to delegate is really difficult, especially as a new surgeon, because you want to control everything, but that actually in the long run will help you. Now, the difference is just saying, oh, they'll handle it and I don't have to worry about it. Wrong. You need to be there. You need to get everyone involved. You need to be the captain of the ship. And I do think that there are some institutions, specifically here, where they do like a post timeout, where you can reflect back and say, you know what, team, we did a really good job on this. Maybe next time we should identify what we could do better. And then taking ownership. If you have a complication, even if you are not the direct result of that complication, your name is at the top of the list and you are taking ownership of that complication for your patient, and never blame anyone on the team. So let's go back to our patient. She's completely dislocated, no facet fracture. She's awake. She can talk to me. She can participate. So what do I do next? Using the learning objectives that we just talked about, approaching the patient with an expedient full spine exam, making sure that the patient had full spine imaging. We didn't talk about specific trauma classifications, but this patient technically is a C7T1C type C fracture with a bilateral facet injury. And my goals, what are my goals of this patient? So I need to reduce her. I need to, in reducing her, will allow for decompression of her spinal canal and then restore her biomechanical stability. This fluoro exam is from her awake closed reduction. She was only 120 pounds. I only got her to just there. You can see that I'm still not anywhere close. And I maxed out at 90 pounds. So what do I do next? At our institution, we get an MRI after an unsuccessful closed reduction. in an awake patient. And this actually presented with a complication. I had a issue with the OR staff allowing me to get a patient from the OR to reduce her back to MRI and then back to the OR to open reduce her. And we identified that and we discussed it in a QI meeting. And now that is been improved as a workflow. Then we took the patient back and attempted a close reduction with complete relaxation using neuromonitoring and baselines. Prior to that, it was unsuccessful. We did a posterior approach, knowing that this patient was thin enough to likely get to the C7T1 area, but probably not thin enough for an anterior T1 corpectomy. And if you aren't able to do what you need to do in full, you shouldn't start with that approach. And so we went from the back, we opened her up, we still couldn't get her reduced closed. So what we had to do is shave off the superior articular facets at T1 in order to reduce her. And we did a laminectomy even though she was intact because we could not reduce her adequately and feel like we were safely reducing her canal. This is now her post-operatively. I actually got to see her at her 6-month post-operatively and she's doing really well. In summary, approaching a trauma patient with a spine injury can be difficult, but knowing what your goals are and best utilizing your resources is paramount for your institution. Utilizing your trauma classifications in order to make your workflow better is really a good tool and technique. Understanding your goals of surgery, calling your mentors and your partners in when you need it, and optimizing your team in order to handle your difficult situations. Thank you very much. I left my email if anyone has questions or wants to discuss further after the talk. Feel free to email me anytime. Thank you.